Good morning, everyone. Welcome to the 22nd Northwest Patient Safety Conference. This session is titled Cultural Safety is Patient Safety, Reporting and Responding to Indigenous Specific Racism and Discrimination in Healthcare. My name is Anita Sulaiman. Please note that all presentations are recorded. Presentations, slides, and speaker contact information will be available on the conference website after the conference. Educational credit information will be sent out after the conference. This presentation will conclude with a Q&A. If you have questions, please submit them using the chat function that you can find at the bottom of the screen. Our esteemed speakers are Andrea Walker, Heather Hastings, and Nona Waters from Provincial Health Services Authority. Please welcome our speakers. You have the floor.
Thank you so much, Anita. Good morning, everyone, and happy Friday. If we could go to our next slide, I wanted to start off before we begin with land acknowledgement. I'm joining this morning from the unceded, ancestral, and traditional lands of the Musqueam, Squamish, and Tsleil-Waututh First Nations. I'm a white settler with English ancestry and acknowledge the privilege that me and my family have from being on these lands, and affirm my commitment to doing the hard work to eradicate Indigenous specific racism and discrimination and ensure the care provided to Indigenous patients and families is culturally safe. In Canada, we're committed to doing land acknowledgements at the start of formal meetings to raise awareness of Indigenous land and rights, inspire reflection, and share our commitment to reconciliation. Reconciliation is ongoing work. The harms done to Indigenous peoples in Canada are shamefully part of our history, and the impact of this history reverberates into present day. What has been done in the past is not our fault. We weren't actually there ourselves, but we need to have the courage to learn the truth of the past and examine where we are now and work together to collectively do better. I'm Andrea Walker. I'm the Chief Quality, Patient Safety, and Experience Officer with Provincial Health Services, which is located in Vancouver, British Columbia. And I'm joined today by my friends and colleagues and partners in this work, Heather Hastings, who's the Executive Director of Indigenous Cultural Safety and Transformation, and Nona Waters, who's the Executive Director of Risk Management, Compliance, and the Patient Care Quality Office. We are all registered nurses by background and have worked very much in partnership to do the difficult work that we're excited to share with you today. If we go to our next slide, it provides quite a bit of detail on the overview of the project. Sorry, this is our agenda. High level, you can go to the agenda slide, that's fine. It provides a high-level overview of what we're going to talk through today, and we are hoping to get to 10 minutes of questions for questions and answers at the end. If you could skip ahead to the next slide, please. And again, one more. Thank you. These are our project goals, objectives, and outcomes. I know it's quite wordy, so in a high level, the focus of our work was to develop a reporting and review process to respond to racism and discrimination to Indigenous peoples receiving care from any of our clinical service delivery areas in our health system. The goal of these reviews, there are two goals. One is to identify and implement system recommendations to provide culturally safe and anti-racist care. And the second goal is to get to meaningful resolution where we can with the harmed patients and families to restore their trust. Go to our next slide. This slide has our learning objectives on it, which I know are in your conference information, and I trust you've taken a look at those because that's why you're here today. You're interested in that. You can just skip ahead to our next slide, please. Thank you. High level is to just understand why we need to do this work. Secondly, to discuss the key change enablers to make work like this successful. And then lastly, we're going to go through a case study with you to really show you how this plays out in practice. Next slide, please. This is a bit about our health system. Located in British Columbia, we provide cancer care services across our province, emergency health services. We have the Centre for Disease Control, mental health and substance use, which includes corrections and forensics, and children's and women's care. And our next slide shows you on a map what that looks like. You can see we have around 400 locations across the province of BC and 28,000 employees. Thank you. Next slide. I'm going to hand it over to Heather, who's going to provide us some of that context and background information on why we needed to do this work.
Yeah, thank you, Andrea, and thank you for having us here today. So what we are going to speak to today is really about the history of colonization and the current impacts of settler colonialism within Canada. I encourage you, wherever you are located, to explore the truth of the lands that you currently are residing on. Go ahead and move to the next slide, please. Oh, almost. There we go. Thank you. So settler colonialism in Canada is not just a historical event, it is an ongoing structure that shapes our systems, policies, and practices. Indigenous people have been living on these lands and waters since time immemorial, with unique and diverse and distinct systems of governance, economies, education, and knowledge. Populations were in the millions with tremendous diversity between and within nations, each practicing self-determination and complex social organizations. The belief in European superiority over Indigenous peoples justified policies and institutions designed to displace, marginalize, and control Indigenous communities. Examples of this in Canada are the Indian Act, residential schools, Indian hospitals, the pass system, and the dispossession of lands. These colonial structures did not disappear. They continue to shape healthcare systems today, embedding Indigenous-specific racism, limiting access, and excluding Indigenous leadership from decision-making. As a result, Indigenous patients often face dismissal, stereotyping, denial of care, and unsafe experiences, contributing to poor health outcomes and the mistrust in the system. Addressing settler colonialism is critical because these harms are systemic, not incidental, and require structural solutions. By recognizing the ongoing impacts of colonialism, implementing culturally safe practices, centering Indigenous leadership, and acting on evidence and guidance from frameworks such as UNDRIP, DRIPA, and the Truth and Reconciliation Calls to Action and the In Plain Sight report, we begin to dismantle racism, restore trust, and build a health system that is equitable, safe, and responsive to the needs of Indigenous peoples. Go ahead and move to the next slide, please. Thank you. There are legal and legislative grounding for this work that has been developed over time to address the impacts of colonization and Indigenous-specific racism in the healthcare system, grounded in documents like these on your screen. Together, these foundational documents establish and assert that health inequities are systemic and structural rather than individual failings, affirming Indigenous peoples' legal and inherent rights to equitable and culturally safe care. They provide guidance, accountability, and actionable pathways for transforming policies, practices, governance, and health systems, while collectively recognizing past and ongoing harm, asserting rights, and setting standards that shift power towards Indigenous leadership and self-determination. These documents reinforce that reconciliation isn't optional, but requires systemic change, culturally safe practice, and ongoing evaluation of outcomes. They signal both responsibility and opportunity, the responsibility to dismantle racism and the opportunity to build a health system that is equitable, safe, and responsive to the needs of Indigenous people and communities. Go ahead, go to the next slide. Thank you. So within PHSA, there are specific foundational documents that we rely heavily on, some being the In Plain Sight report, the Health Standards Organization, Cultural Safety and Humility Accreditation Standard, and DRIPA, the DRIPA Action Plan. But also within BC, we receive mandate letters from the Ministry of Health that supports the work to address and eradicate Indigenous specific racism, and the established North Star priority by PHSA leadership, as you can see here. Go ahead and move to the next slide. The In Plain Sight report, authored in 2020, draws on the experiences of over 600 Indigenous patients, families, leaders, and healthcare employees, highlighting widespread Indigenous specific racism, stereotyping, and discrimination in the BC health system. As you can see in the schematic here, prior to colonization, which is right up in the top sort of like 1130 on the schematic, prior to colonization, Indigenous people had thriving systems for health, governance, language, and community, many of which were disrupted through the loss of colonial policies and practices. The healthcare system was built on these colonial foundations without recognition of Indigenous needs or inclusion of Indigenous voices in the development. Harmful stereotypes such as Indigenous patients being seen as less worthy, non-compliant, or frequent users of services have shaped discriminatory practices, including denial of care, shaming, inappropriate pain management, and unnecessary involvement of child welfare authorities. These practices create barriers to care, erode trust, and discourage Indigenous people from accessing health services, which contributes to poor health outcomes such as higher rates of chronic disease, higher infant mortality, and lower life expectancy. To break these cycles, we must understand and assert Indigenous rights to health, uphold self-determination and leadership, and commit to ongoing education and systemic change that ensures anti-racist and culturally safe care. By doing these things, we hope to improve societal knowledge of racism and discrimination. This education will challenge stereotypes, address discrimination, and ideally lead to the increased trust in the system, decreasing barriers to access, and improving health outcomes. Next slide, please. We also rely on the guiding work of addressing racism in healthcare. We draw on Jody Wilson-Raybould, former Minister of Justice and an Indigenous leader within BC, and Dr. Kamara Jones. In Jody's book, True Reconciliation, she lays out a three-step approach to learn, understand, and act. Learn, seek knowledge about Indigenous history, rights, and systemic inequities. Understand, reflect on how this history and ongoing colonialism shapes current systems and experiences. And act, apply this understanding to make meaningful changes in policy and practices and relationships. Alongside Dr. Kamara Jones's framework, name racism, which is to clearly identify where and how racism is occurring. Ask how racism is happening here. Examine local structures, policies, and practice, and strategize to act. Develop concrete actions to dismantle racism and improve equity. These frameworks provide a structured approach to reviewing events and complaints for Indigenous specific racism in healthcare. By grounding our review in the lived experience of Indigenous patients and families, we learn where and how racism, stereotyping, and discrimination is occurring. They guide us to name racism explicitly and develop actionable pathways to respond. Go ahead and move to the next slide. And I think I pass over to Norna. Thank you.
Thank you, Heather. And thank you all for having us here today. So Heather has really explained the foundational documents that guide our work and set us up for where we needed to go. But we also wanted to share with you information on what we needed to do in our culture, within our teams, within our organization, in order for this work to be successful. If you could go to the next slide, please. So this work that we're doing is guided by Coast Salish teachings that were gifted to us by knowledge keeper CM Tita and Shane Point. And I'll just go through those a bit to help you to understand how these did guide us. So Thi-Eat is the truth. We need to acknowledge the harms that Indigenous people have experienced within our system. Islaxin is good medicine. We need to see how we can change our system to be good medicine for all. Nutsamat, we are one. We need to work together to do this work, this challenging work, and make sure that we're strengthening and improving the care that we are providing. Waktuks and Chalawin, open your hearts and your minds. We need to unlearn this colonial narrative that's grounded our system and understand how we can do things differently and be okay that it's uncomfortable, because sometimes it is, to face the truth. Come Stun Chalawin, make up your mind to be strong. this work has not been easy. It has had many challenges along the way, which I'll go into, but we worked together to really be able to implement this new way of reviewing events that have happened. And team up it to do your best. We need to show up in a good way, and we need to know that even when it's challenging, we need to find the best way forward. So if you could go to our next slide, please. There's also many things that we needed to put in place within our organization in order for this to be successful. We needed to do a lot of work at the beginning to understand how were we going to set up these reviews so that they will be successful. And that took a lot of engagement with many different teams in order to do that. We also needed to set up the right frameworks to make sure that we had accountability and transparency and reporting around this work. We set up very specific engagement committees. We report this to our board. We have engagement with senior leadership in our executive leadership team, and we know that we have their full support for this work, and that was really key for us to be able to move forward. We developed a lot of communication and education, and some of that you'll see today in our session, so that this was new learning for everyone. And so we had to spend the time to make sure that people did understand why we needed to do this and the background behind that. We developed, with the help of our Indigenous colleagues, an Indigenous-led resolution guide. So we understand how we can, as Andrea said at the beginning, make sure we're making things right for the Indigenous patients and families that experience harm in our system. We also had to develop policies and procedures and change other policies and procedures, all to make sure that this work could be successful. So just for you to think about, if you're planning to do something similar within your organization, really knowing that it's not just something that you change and say everyone does this now. There's a lot behind it that has to happen. If you can go to our next slide. I think I've mentioned a few times that we had some challenges, and so just to go through those a bit there that you might experience similar. We definitely faced resistance in different areas. People were uncomfortable. This was new work. Sometimes people hadn't done foundational education that a lot of us had done, and so we needed to encourage people to do that, to begin to understand. We were developing this before we had the education developed, so we were doing things all at the same time. So it was hard for people, but we took the time to allow people to have that education. We also really came to know that these events were really hard for our Indigenous colleagues to be participating in the review of. And so we made sure we put supports in place for that, such as a monthly elder-led debrief and ways for our Indigenous colleagues to come together to feel supported while doing this hard work. And of course, it was new work and we didn't necessarily have all the resources attached, so it was increased workload for everyone, and that was challenging. But we've really tried to have the support of our leaders to put in the extra supports and resources in place, and that's really helped us to be successful. I believe I'm now handing it back to Andrea, who's going to go over our next section. Thank you.
Thanks, Norna. If you could just advance us to the next slide. I'm just going to provide a high level of the steps of the work we did to date, and then we'll get into a video case study. You can go to the next slide. Our first piece of work was really discovering that we needed to develop a new pathway forward. What we were currently doing, which was really not looking robustly at how racism and discrimination was operating in our system. Or if we were doing it as part of a patient safety event review, and those processes were not working adequately to do this work. So we first of all needed to recognize we needed a new way forward. Secondly, as Norna mentioned, we had to pull people together across our organization. You saw in our slide at the beginning that we provide a variety of specialized services. And so we know that engagement is so important when you're doing significant change work. And so we formed an advisory council that had representation from across our health system to review and provide feedback into what we were proposing. Here in BC, we have what's called a patient safety learning system. You likely have something similar where you are, and it's where staff report safety events or even near misses
that get reviewed to try and get upstream and prevent future occurrence. What we did in that system is we added indigenous self-identification. So we are able to determine when an indigenous patient experiences a safety event. We also added a question on, was racism and discrimination a contributing factor to that event for when our reporters report about a safety incident. So that was really important in setting up how these reviews would move forward. We created a system-wide committee. We called it the FEET, which is the Coast Salish Teaching for Truth, an Indigenous Specific Discrimination Response Committee. This committee meets weekly and is accountable for the initiation of reviews. So it's looking at initial events as they come through, either staff reported through that patient safety learning system or patient and family reported through our patient care quality office. It's taking that initial look at those events, helping to set up our review committees, and then has accountability for reviewing the final reports that come out from reviews, which include those recommendations for system improvement, as well as the resolution approach, if we were able to get to that with the patients and families. If you go to our next slide, please. We did set up a robust evaluation plan, which we've not completed. We're still in our implementation phase. We developed a protocol. Norna mentioned how important it is that you have clarity around steps in the process and roles and responsibilities of different team members in this work. And so we have a protocol with tools and templates. And then what we have in progress is we're working to create a dashboard that will oversee recommendation implementation. It's one thing to make those ideas and suggestions for system improvement. It's a whole nother to follow through that they're actually implemented and have been evaluated to address the harms that we're seeing. And then lastly, our education strategy across the organization as we work to make this system-wide. And so we'll share a little bit more about that later in our presentation this morning. If we go to our next slide, this is our case study video. I think this is probably the meat of what you want to know. And this is how these reviews play out in practice. So we'll let that play now. Thanks so much. Except we need sound. So I'm hoping you can fix that on the conference end, please.
That you can't hear it? Okay, hold on.
With a
Can
breath.
you hear it now?
She remained in the waiting room for hours post-triage. And despite Margaret saying her pain is worsening, staff are dismissive, and she overhears someone say, "I don't think her pain is that bad. She can wait. I think it is drug-seeking behavior." So Margaret overhears this and gets upset, and then security is called. Elena, who's a staff member, happens to be walking through the ED and witnesses this incident. So Elena's acting as our person who witnessed this scenario. So take me through how you would have responded based on the protocol after witnessing the incident.
Sure, thanks, Tracy. So I walked into the ED and overheard conversations surrounding an Indigenous client and noted that security was involved. I could see the client was visibly upset in the waiting room, so I approached her and introduced myself. The client introduced herself to me as Margaret and told me that she had heard them say, "I don't think her pain is that bad. She can wait. I think it is drug-seeking behavior," and said that she'd been in the waiting room for hours. Margaret was visibly struggling with her breathing. It was labored. During our conversation, she was admitted, and they attempted to have her walk, but I requested a wheelchair, which was provided due to her shortness of breath. Based on what I had heard, I determined that this was probably an incident of ISRD. And I remember that I had recently read the new ISRD protocol and went through it in my head. So I had removed the patient and addressed her needs. I'm in Indigenous health and I'm aware that we don't have an IPN at the moment. So I wondered what I could do and figured that since I was in Indigenous health, I would support Margaret through this. Once I finished with Margaret, I considered communicating with the people involved, but decided against it because I feared retaliation. But I did inform my manager of the incident, and I created a PSLS event. Some key takeaways for me was the lack of cultural humility in the ED, the implicit racism by the comment made, and calling security for an elderly woman. I also had a concern that we didn't have an IPN on staff. I noted all of this in my PSLS event and the email that I wrote to my manager. I'll pass it over to Kira.
Thanks, Elena. So my role in this review process is of a handler, PSLS handler. As a handler, my first role or step is going to be that I'm going to review the PSLS report that I was notified about, check all the initial event details, and complete any kind of blank or missing fields that I may see to the best of my knowledge. I will next make sure that I update the contributing factors to ensure racism and discrimination box is checked off if I suspect I is already involved in the event description. And I'll make sure that that box is checked off, even in instances where I may not be super sure, just to make sure this event gets escalated and the right leadership gets involved from very early on. I will then review the patient chart to get information on Indigenous self-ID and check the PSLS box on self-ID accordingly. If I do not find that information on the patient chart, but I have information on PSLS itself or other documentation that indicates that the patient self-identifies as Indigenous, I'll make sure that information is reflected on the patient chart. As a next step, and in accordance with PHSA guidelines, I'll assign this event a harm level 3 or higher. This is also outlined on the quick reference guide for PSLS handlers that is available on POD and will be shared with you all later. I will then notify my leadership, which is the operations manager, or if medical staff is involved, a medical lead. If I myself as a handler am in one of those roles, I'll follow my steps in accordance with what's outlined on the protocol itself. And last but not the least, I'll support the ISID review process by collecting any kind of background information on the case in collaboration with the quality team, risk team, and program Indigenous health team. And with that, I'll pass it over to Elena to go over her role as an Indigenous health team member in this case.
Wonderful. So in this circumstance, I was the reporter and I was involved in the incident. However, as an Indigenous health staff, I hold a responsibility in the protocol as well. So in that role, I'll get the PSLS report. I'm going to review the PSLS details and just ensure that everything's in there and I have a clear understanding. Then I'm going to confirm that the patient and family are supported. So I'm going to connect in with them. I'm going to connect in with operations and kind of be a bit of a bridge. I'm going to ensure a culturally safe disclosure. So engaging with the patient and family where it's appropriate and supporting that engagement. Collaborate across teams. So PHSA Indigenous Health supports program teams as needed in these review process. I'm going to participate. So again, because I was a reporter, I might be involved in that way, but separately as my role in Indigenous Health, I'm going to participate in the committee intake and provide anti-racism analysis. So what that means is walking alongside the quality team, risk team, and operation leads during the review, and just ensuring that we have that Indigenous perspective throughout the review. Oh, and then I'll pass it to Shyla.
Perfect. Thanks, Elena. So in this case scenario, I'm going to be acting as the operations lead. So when I receive a notification of an event in PSLS that involves Indigenous specific racism and discrimination, the first thing that I'm going to do as that operations lead is to review the event details to try to get a baseline understanding of what happened. Once that happens, I'll then notify the program directors and executive leads to make sure leadership is aware early on as appropriate. I'll then reach out to the Indigenous health team to discuss next steps. Together, we assign a lead for the initial review and talk about what supports the patient and their family might need. Elena mentioned this earlier, but we also consider whether disclosure is appropriate at this stage. So I want to make sure to connect with any staff as operations lead who was involved in the event. It's really important to confirm that patient care remains safe and culturally appropriate. I'll also be checking in on the staff's well-being, and if medical staff are involved, I'll ensure that the medical lead is notified as well. From there, I coordinate with our quality and risk partners to plan the next steps in a very collaborative way. Together, we review a document that's called Guiding Criteria for Triaging PSLS Events that include an Indigenous patient. So quality and risk have access to this, and this helps to determine if the incident needs to be reviewed by the FEED and ISRD response committee. When it's time, I co-present the event with my quality, risk, and Indigenous health leads and colleagues at the ISRD response committee intake meeting, making sure we highlight both the clinical as well as cultural safety aspects of the case. And really throughout the process, I ensure PSLS is updated with the latest information, and I'll either enter this myself or inform the PSLS handler so nothing is missed. I'll pass it over now to Kate, who's acting as the quality lead in this scenario.
Thank you so much, Shyla. So as the quality lead, when I'm notified of a PSLS event that involves Indigenous specific racism or discrimination, I'll start by reviewing the event details to get a clear understanding of what happened. From there, I will connect with key partners, which could include operations, risk, and Indigenous health, to discuss the event and decide together on the appropriate next steps. One of my main responsibilities as a quality lead is to facilitate and guide the discussion on whether the event meets the criteria for review by the FEED and ISRD response committee. As Shyla mentioned, I can do this by using the guiding criteria for triaging PSLS events that involve an Indigenous patient, which is the document that supports this decision-making. If we determine the event does meet the criteria, I will work with my colleagues to co-present the event at the FEED committee's intake meeting. If the event does not meet the threshold for review at the FEED committee, I still take the time to complete a concise review, making sure the event is tracked and trended for system-level learning. Through this process, I ensure we follow the patient safety event review protocol so that the event is properly reviewed. Now Tracy will speak more about this committee.
Thanks, Kate. So in the previous presentation, I talked about the role of the FEED and ISRD response committee. So in this case, if we're using the same scenario, Kate and Shyla and Elena would meet to discuss presenting an overview of the incident prior to coming to the FEED and ISRD response committee. So then they would be invited to this committee, and they're going to go through the details of the case, and then it's going to give the FEED and ISRD response committee members an opportunity to ask some questions and provide some feedback, and again, answer any questions that they may have. It also needs to be approved by the FEED and ISRD response committee to move forward as a program ISRD review. So now Shyla, as the operations lead, she's going to provide an overview of the case I'll provide an overview of the case with Kate, and Elena will be there to help support her through that. And then the next step is to go back. So we're going to say this has been approved by the FEED committee, and then Shyla's going to go back and go over this with her team, as with operations and with Kate and with Elena, to set up the ISRD response committee. And Shyla's going to take you through this. Perfect. Thanks so much, Tracy. So what this slide does is just provides an overview of the key responsibilities for those involved in the program ISRD review committee. And so first and foremost, in terms of the quality team, every member plays an important role. But I think hopefully what was clear to you all in the context of the case scenarios that the quality team helps facilitate the setting up of the review committee, certainly participates in the discussion and analysis, provides guidance on the review process, as well as plays an important role in facilitating the completion of the ISRD review report. Next, the review committee chair is really the designate who leads the review and ensures members understand their process and understand their roles, and plays an instrumental role in keeping the review discussion on track and focused on this systematic issues, and keeps the patient and family at the center of the discussion. So they play a really pivotal role, really helping to lead the review process and those discussions. There's a number of members of the review committee. And so in this scenario, we just reviewed, myself, Kate and Elena would receive the intake summary from the DE and ISRD response committee and would work together to set up the program ISRD review committee. And so that can include identifying a number of suitable members for this committee, which typically includes operations, quality, risk, indigenous health, a medical lead, and a professional practice rep. There might be other designates that are also deemed to be important to include as members of the committee. So it's a collaborative discussion up front to really thoughtfully think through who makes the most sense and who best would serve to be a part of this committee, depending on the event itself. And last but not least, the designate of the committee is someone who connects directly with the patient and family. Tracy touched on this earlier and the important role that they play. So in the context of the case study, Elena, who reported the incident and is a member of the Indigenous health team, was designated to be this connection to the patient and family. Ultimately, again, as Tracy mentioned, this designate is someone who has a good relationship with the patient family, even if they're not part of the review committee. The goal is to really enact and keep in mind a patient-centered approach, and ideally ensuring that the patient and family are comfortable with who this designate is as they work towards a resolution approach. So with that, I will pass it over back to you, Tracy. Thanks. So as Shyla mentioned, someone will be a designate as the contact for the patient and family. And in this case, it'll be Elena from the Indigenous health team. So Elena has connected with Margaret, and Margaret would like the staff to know how their behavior impacted her. She's asked for a healing circle and would like the care team to attend. She's also indicated that she's bringing her niece, Leah, to be her support person. So Shyla, as the operations manager, has reached out to those involved, and a physician, a nurse from the care team has agreed, and also the security guard that was involved in the incident. So Shyla has also consulted with Elena, and they've agreed to co-facilitate the healing circle. Elena connects with Margaret and Leah also to ask if it's okay if Kate, as the quality lead, can attend the circle to document the discussion for the report and also any learnings that come out of the learning circle. And Margaret and Leah agree to this. So next, we're going to take you through a little video that we've created that shows you what a healing circle might look like. But because we don't have a lot of time, it's quite short, but in reality, a healing circle can take anywhere from, an hour to 3 hours, depending on what happened, the size of the group, and what the patient's actually asking for. So keep that in mind when you're reviewing the video.
Welcome, everyone. I appreciate your presence at this healing circle. We gather here today to listen, share, and support each other as we heal from the pain related to Margaret's emergency visit. This is a safe and respectful environment where every voice is valued. Margaret, we invite you to share your story now.
I sat there for what felt like forever. My chest was tightening. I was struggling to breathe, and no one seemed to see me. And I tried to speak up, told them my pain was getting worse. But it felt like my words just vanished into the air. They didn't listen. They just ignored me. And then I overheard someone call me just drug seeking. And that hurt more than I can say. It stung like a slap, cutting right through the core of me. I'm not just a label. I am a mother, an aunt, a knowledge keeper. I've walked through fire, fought through storms. But to be treated this way, have my concerns dismissed like they don't matter, that's not care. That's not safety. Feels like I'm nothing, like my pain doesn't count. We, my people, we deserve better than this, and I deserve better than this.
My auntie is such a wise woman and a really respected member of our community, and she means the world to me. It is so heartbreaking to see what she had to go through. I hope as members of this organization, you all take a look at your processes, especially the ones that fail to offer culturally safe care. Please think about how unconscious biases can show up as racism towards Indigenous peoples. I am asking you to approach Indigenous peoples who seek care with kindness and humility, no matter what their situation is. And thank you for being open and having this discussion today.
I recognize the presence of systemic and organizational racism within the system, and I'm motivated to contribute to meaningful change. Initially, I believed I was adhering to protocol and that it was acceptable for Margaret to wait since her pain appeared manageable. However, I now understand that her lack of response was influenced by multiple factors, and I should have been more observant. My own implicit biases also affected my judgment in the situation.
I listened to colleagues share opinions suggesting that Indigenous peoples only come to the emergency department for drugs. And at first, I didn't give it much thought. Growing up in a setting where stereotypes were prevalent, I accepted those notions as truth. However, I had come to understand that I hold implicit biases, and I am motivated to learn more and play a role in resolving the issue instead of continuing this cycle.
Come to understand that I carry implicit bias. I see now that I was wrong to assume Margaret was at fault. No one wants to be in hospital. People go there because they need care. While I'm now a healthcare provider, doesn't mean I can't show empathy and concern, no matter the situation. I see now that I could have done more to listen, to be more aware, and show respect.
Thank you. Margaret, do you have anything else you would like to share today?
I want to thank all of you for being here today and for taking the time to listen to me and to my niece and to each other. I hear a commitment to do better and make changes. I want to ask that you share your experience here today with your colleagues, just as I will share mine with my community.
I really appreciate everyone's honesty, openness, and dedication to the healing process. I hope this gathering will mark the start of significant change and the development of deeper relationships founded on respect and understanding. We acknowledge Margaret's courage and the insights of everyone present here today.
I know that was a long video, but we really wanted you to get a sense of the details of this review process and what it looks like. If you can advance to our next slide, we'll just wrap up.
Through. This is
We'll just wrap up our presentation here in the next few minutes. Once the review is complete, this report goes through an approval process, which is outlined here, and we close the loop with our staff that were involved or reported the incident, and then share learnings across our health system where we can, and then get to monitoring those recommendations so we can start to see improvements in the care. If we go to our next slide, please, I'm just going to give you a high-level overview of our education strategy. Next slide again. What we have across our organization, I'll pause here and just mention Senator Murray Sinclair, who was the chair of the Commission for Canada on writing our Truth and Reconciliation Calls to Action. He is an Indigenous judge. He left us this very important quote that says, "Education got us into this mess," and what he's referencing is the residential school system in Canada. But that education will get us out of it. And we very much believe that and have put a lot of time and energy into education in this work. Our next slide, please, shows the education strategy for across our organization. This education is not specific to the review process. It's foundational education so that our staff, leaders, clinicians have a good understanding of why we need to do this work and what their role is in it. There is mandatory education for all of our staff, some foundational education on addressing Indigenous specific racism and discrimination in healthcare. And then as you can see here on this slide, there are advanced workshops and additional training that many of our leaders are going through currently as well. And this is one of those culture change enablers that Norna spoke to that's really laying the foundation to enable this work to be successful. The next slide, please, provides an overview of the education strategy specific to the implementation of this review and reporting process. We've spent some time, all staff, there's a 20-minute e-course for all staff to take that helps them see their role in speaking up and how to report these events when they witness them. Specific education focused on medical and operational leadership, so they know their role in these reviews. We've done so many presentations on this work across our organization to meet this need. And then finally, we needed experts in the review process. And so these are our quality and safety, Indigenous health and risk teams that truly are experts in walking through all the steps in the protocol and can come alongside our operational leaders if they have an event that occurs in one of their areas. So they attended half-day workshops to really work through case studies and get comfortable with the process and the reports involved. Go to our next slide, please. I'm going to hand it over to Heather to just give you a bit of information on the data and the volume of what we're seeing and some of the system recommendations.
Next slide. So as mentioned earlier, this really is in line with the recommendations of the In Plain Sight report, including recommendation 4 that talks about reporting issues of racism relating to Indigenous peoples and supporting Indigenous peoples who are encountering racist behaviors and policies and practices within the healthcare system. This year, we did our first report that summarizes the 71 events between November 2022 and September 2025. This gives us a snapshot of what we're seeing across all of our clinical service delivery programs, highlighting systemic contributors of racism and opportunities for meaningful change. Maybe I'll just move to the next slide. I think you'll have this in your package so you can look. This slide too, it's quite busy, but it just provides some of how we did some of the outcomes of our reviews and some of the recommendations for system change that came out of them. These are a couple of examples. Typically, we try to, when we're doing the reviews and to develop recommendations, that we look at the systems, policies, practices, structures, as well as people and education. So they're much more built out than this, but just a couple of examples for you to review on how we may look at these examples or these experiences and create system change across our organization. And you can move to the next slide. And the next slide. Yeah, so this is where we're at right now in our organization with this work. We recognize that this is new. This is a new process within our organization, but also across BC. These recommendations and actions have been put in place for a while, and we're working towards a more responsive process. But we also know that we continue to learn, which requires more evaluation and refinement of the process over time. It's going to continue to need ongoing education across all of our organization, from the leadership level to the point of care level, so that we can recognize racism as it's happening, but also within leadership to really action change and hold the organization accountable. I think that's all I'll say to that next steps piece. And we can move to the next. Yeah. Thank you, Heichka, for coming today and asking already some questions in the chat. I appreciate those, and I'll hand it back to you.
Thank you. That was such an illuminating presentation. It is wonderful to see your organization's approach to Indigenous specific racism and discrimination, how much heart you put into this, into creating a culturally safe environment. So I hope everybody's enjoyed it as much as I did. Moving on to the Q&A, there has been some conversation. There are answers already to some of the questions, but for the benefit of the folks who were, focusing on the presentation and haven't had a chance to look at the chat, I'm going to cover some of those as well, if that's all right. So the first question is, can patients directly report incidents, or does it need to be submitted by a medical staff member? And one of you has answered that yes, patients can report incidents, and that is mainly through our patient care quality office. Acronyms have been explained, so the audience is welcome to go check the chat at this point. Next question that needs answered is, how do you account for implicit bias at the handler level? Are all events involving Indigenous patients reviewed through this process, or only those where racism/discrimination is checked off as a contributing factor?
I can take that one. The racism and discrimination question is quite new, and therefore we are not relying on that to be the only way to signal that we need to look at this from a racism and discrimination question. So yes, all patient safety events where an Indigenous self-ID is indicated is being looked at. And most important to us is that we involve Indigenous leaders in reviewing those events to help us determine what needs to be reviewed or brought forward to the committee for consideration of how racism and discrimination was operating in that event.
Right, next question. Thank you for that answer. PHSA and BC's other regional health authorities collaborating or working independently on this? To what extent are the program change approaches taken within PHSA versus other regional authority facilities similar or different? So would you like me to just read through the responses, or would you like to respond verbally?
I can respond verbally, and maybe I'll do it shorter than that's in the chat. But I'd say that across the province, we all hold the same obligation to the mandate letters, as well as the in plain sight report and the DRIPA action plan. So we all have been given the same sort of responsibilities to do this work across the province. That being said, we aren't all expected to do it exactly the same way. So that's not necessarily what's happening. But I would say that there's many sort of, if you were to contrast and compare the regions to PHSA, there's similarities and there is differences, but I'd say specifically around this one is the self-identification of Indigenous people within the patient safety learning systems really gives us a really good idea of where Indigenous people are showing up in our organization and the ability to act more in the moment, whether or not it's something that's coming through, and being able to surround them with care, as well as being able to review these. First of all, one-on-one to be able to help support that family, but also to be able to gather themes and understanding how racism is showing up across all of our organization. And then the recommendations to systems change is something that I'm not sure that is happening consistently across the province as it is within PHSA. And then there was a question about FNHA in there. So FNHA is the First Nations Health Authority within the province. And so, David, you must know some things about the province, so that's great. But so we have had conversations with FNHA about this work. They have interest in how we're generating recommendations and themes out of the complaints and events that we're seeing, but they aren't necessarily here or connecting in as an oversight within provincial health services authority, but as a partner in some of this work, sort of more broadly.
Thank you. I am not seeing any other questions, but I have a question. I cut my teeth in consulting, doing business process reengineering, and I'm really impressed with how nicely done your processes are. The roles are so well defined. The structure is very well thought out. How long did it take you to come up with that structure, and how much? Who were the people involved in creating that?
I can maybe take the first go at that. This has been probably the most challenging, it's not probably, this has been the most challenging piece of work that I've been involved in my career. When I took my role here in patient safety and quality, I never thought, it wasn't on my mind to think that cultural safety and addressing racism was part of my work. I thought it was all about like medical harm, et cetera. And so this was a long journey, I think, for us to see that this is part of patient safety work and part of our team's work to address and do. I think this has been 2.5 years or so, maybe even almost 3 years of us first from realizing we needed to do this work differently to where we are today. The number of PDSA cycles that it took us in testing out this process is really each new case that came forward, something new would come up and we'd say, oh, we didn't think about that. We need to do that differently. Oh, that didn't really work last time. Let's address that and try it differently. And so we were constantly tweaking, updating, revising. And we're at a point where we have a published protocol now, but I don't think the work is done. We just got to a place where we needed to stop making little changes to the process and get something out there and educate our staff on it, knowing that we're going to need to continue to do continuous improvement. And I expect there are efficiencies to be had and improvements that will come as we continue on our journey. And then who was involved in the work? The three of us were really co-leads in doing this, and we had executive sponsors that supported us very much, which was really one of those culture change enabler pieces that was so essential at our vice president level and CEO level, support for this work. But it's really our teams that are actually in our clinical service delivery areas that are doing the hard work of leading these reviews, having the difficult conversations, identifying the system improvements. And so it's all of our teams and all of those that we work with that have enabled us to get to where it is today.
Thank you for sharing that. So a couple more questions have come in. We'll see if we have time to cover both. And then there's a comment too from the audience. First question is, have you seen an increase in PSLS reports for Indigenous clients after implementing this work? Recognizing that we know racialized groups often face harm at a higher rate, but a lower reporting of events into voluntary reporting systems.
It's hard to know if we've seen an increase because we weren't tracking it before. So we don't have data on before to say if we're seeing an increase in Indigenous patient safety events. But we do know when we're just starting to pull our data to look at the level of harm that Indigenous patients are experiencing in our system, and it is at a higher proportion than non-Indigenous people. And so we are looking into that. Unfortunately, it's not really a surprise to us. We would unfortunately expect that Indigenous patients may be experiencing more harms, but we're just starting to dig into that data to try and understand that more right now.
So we're almost out of time. We've got less than a minute. I don't know if you can have enough time to answer the last question. How much resistance have you had to deal with?
I feel like quite a bit. We've definitely had really hard moments, and I know my team has as well in working to do this work across the organization. I think it's especially hard if people involved in these events haven't done any of their own learning and reflection in why we need to advance this work. and sometimes it feels like an attack on your character. Because a lot of the time, well, most of the time, people aren't coming to work to do something that's going to cause harm or to act in a way that's perceived as racist. These are mostly system issues, and so it does take, it's really white fragility that's showing up when you have to critically look inside yourself and say, how am I contributing to this system harm, and how can I rethink how we deliver care to do this in a more safe way. And that's quite vulnerable to work through with people. And so we have had people, we have experienced quite a bit of resistance, I'd say, and but not always. And I think it really has been our executive support that has said, like, our North Star priority for our organization is to eradicate Indigenous specific racism and discrimination. And so we use the analogy of all paddling together in a canoe. And I think we have a lot of great support around us to help us. But I'd say, yeah, we've had resistance, and it's been hard. This isn't easy work.
And with that, we conclude this very insightful presentation. Thank you so much to our speakers, Andrea, Nona, and Heather, for sharing your experiences, your expertise. Thank you all for attending today. The next session starts at 10:30.